All right, good morning, everyone. Thank you for joining the 6th webinar in the Emergency Preparedness Network's COVID-19 webinar series. Today, we're going to be reviewing pressure injuries during COVID-19, prevention and management. And we have Dr. Madhuri Reddy, who will be joining us as the speaker. She is the founder and director of the Wound Healing Program at Hebrew Senior Life. So let us, I think for those of you who've attended previous webinars, you probably remember me. I'm Dr. Charlene Brown, the CEO and founder of Learn Care Together and also Caregiver Jobs Now. I'm a physician that's working in and around home care and senior care for the last couple of years. And we want to thank the Office of Preparedness and Response, who is responsible for this webinar series. The Office of Preparedness and Response is part of the Maryland Department of Health, and they have a partnership with the Maryland National Capital Home Care Association to support and present this webinar series targeting home care agency, clinicians, caregivers, and other stakeholders in Maryland and beyond. So if you want more information or to join the Emergency Preparedness Network, the website is on your screen. If you're a home care agency in Maryland and you'd like to join MNCA, the Maryland National Capital Home Care Association, you can also find that website on the screen, or just reach out directly to the executive director, who is Dawn Seek at dseek@mnca.org. We have an exciting November and December with upcoming EPN webinars. So this week, Thursday, we have Celeste Wooten, who is a CNA, certified medical assistant, and a certified palliative hospice nursing assistant. She has been doing this work for more than 20 years, and she's doing a webinar on PPE. She's actually training other CNAs on how to properly use PPE, and she's a CNA team lead at her institution. On November 19th, we have Dr. Alan Abrams, my former professor when I was in med school. He'll be talking about dealing with social isolation and loneliness among older adults. He is a geriatrician who is also a geriatric clinical advisor for senior helpers. Beth Galick, you heard her before in August. She gave a talk on dementia management. Now she'll be talking about stress management for home care clinicians during COVID. December 10th, we have MNCA's own Linda Tadasio, who's going to be talking about post-COVID clinical considerations in the home. She's a doctor in physical therapy and just a wise, wise woman. Dr. Abrams is coming back on December 15th to talk about caring for adults with COVID in the home. So December 10th is post-COVID. So what do you do in the period after someone has been diagnosed with COVID, sent home, and you're responsible for their home care? But what about if you're caring for someone who actually has COVID at home? How do you gather community support? And then in December 17th, we have Ama Adepa Grin, who's a CNA, who's going to be basically talking to other CNAs about self-care and caring for the caregiver. So I hope you're going to join us for this slate of exciting webinars. I know that I cannot wait. So now we're going to hear from Dr. Madhuri Reddy. I met Dr. Reddy a couple of years ago through her role as the co-founder and chief medical officer of careacademy.com, which is a leading online caregiver training and education company serving the home care industry. But beyond Care Academy, she is a faculty member at Harvard Medical School. She is a national expert on skin and wound care in older adults and the founder of the Wound Care Center at Hebrew Senior Life. She is a researcher, she's a clinician, she's published articles, written book chapters. She's completed her geriatric fellowship at the University of Toronto, and her expertise in wound care is linked to the fellowship she did in skin and wound healing in dermatology at the University of Toronto. So I am really, really pleased that Dr. Reddy has decided to join us today. And at this point, I'm going to stop talking, and Dr. Reddy is going to teach us and help us understand the special considerations for pressure injuries during the COVID-19 pandemic. Thank you, Dr. Reddy. The floor is yours.
Thank you, Charlene. Thanks so much. So, I'd first like to kind of get an idea of who you guys all are as participants, because as I mentioned to Charlene, that I answer all of your questions and I gear whatever I say towards what you are all interested in. So if you could just type in the chat box something that would help me understand where you're coming from, either your title or where you work, if you're a clinician, anything like that, and what actually you're most interested in learning today, or what you would like to know about. If you could just pop those into the chat box now, it will really give me a good guidance of where to go with this talk. So so I'm seeing home health care. And are you nurses? Are you CNAs or home care workers, or anything you might know already about pressure injuries, or again, what you would like to know? So I'm seeing nurse case manager, nurse clinical manager, unit manager. Oh, Kristen is doing wound care right now. That's great. Yeah, how to best care for skin for limited client patients with limited mobility. Got a couple of hospice. So it sounds like most of the people that I'm seeing now are clinical nurse. I'm seeing medications that help with prevention. There's a question. Okay, so I'll get started, and feel free, please, to continue to type into the chat, and I can go back and forth and ensure that I'm kind of following along with what you all are interested in knowing about. So I'm going to go ahead and share my screen. Okay. Okay, so all right, so let's get started. So I'm going to gear the talk in line with this whole speaker series with COVID-19 and talk about pressure injuries in general, and how management, prevention, or treatment might be different during kind of this era of COVID. One of the things that we had seen in the institution where I work, Heber Senior Life, which has an acute care unit, long-term care, rehab, also home health, home care unit as well, is that it's began in March and April when we started having huge numbers of COVID patients, that we clearly saw a big increase in the incidence and prevalence of pressure injuries. And that has actually, even though it's reduced a bit, it's certainly continued over the last few months. No financial conflicts of interest. Are all pressure injuries avoidable? So let's just start there. And I will say that actually, no, not all pressure injuries are avoidable, not available. Most of them probably are, but it is important, I will say, that if a pressure injury is not avoidable, that you need to document why it may not be avoidable. In other words, you can't just kind of, you can't have a patient who develops a pressure injury and then after the fact state that it wasn't avoidable. I've also reviewed many, many cases for the state and for CMS for cases that have occurred in nursing homes and in home care. So documentation, I know firsthand, documentation for these things are really, really important. They're a very frequent source of litigation. And so in terms of avoidability, a lot of things that I'm going to talk about in terms of repositioning, et cetera, these things all need to be documented in whatever you use for notes, charts, et cetera. So yeah, so probably they're not all avoidable, but you do need to document what you're doing. For the ones that are not avoidable, most of them are due to multi-system failure at the end of life. Skin failure is a real thing, just like heart failure, respiratory failure, or anything else. And I mentioned a couple of things here that are more relevant to institutional care than home care, and that is that CMS does not reimburse if new stage 3 or 4 pressure injuries occur in acute care or long-term care, but that's not quite the same as home care. But again, let me reiterate that a pressure injury is unavoidable only if your facility or home care took every measure possible to help prevent it, but it occurred anyway. And the other thing that I want to add too is that according to the NPUAP, which is the National Pressure Ulcer Panel, it's now changed its name. It's pressure injuries and not pressure ulcer assessment and prevention panel because these are now called pressure injuries as opposed to pressure ulcers. Small thing, but so one of the things that I think it's really easy to sort of get caught up in what dressings to use. And I will say for any chronic wound or pressure injury care that the type of dressing you use is almost really the least important thing. The most important thing is figuring out what the cause of the wound is and addressing that. Because if you can't reduce what the cause of that pressure or whatever else the cause is of the chronic wound, then no matter what kind of magic dressing you use is going to help heal it. And then you kind of have to take your best guess as to whether the wound is healable or not. And I'll talk about how to do that. And only then can you decide what sort of dressing you can use at the end. So this is a patient that we had that we were seeing actually in our clinic that had been managed in home care. We had been seeing him in the wound care clinic in between home care visits. And he was a man, 78 years old, no diabetes, had this right heel wound. Over a weekend, he developed a fever, systemic symptoms, and was admitted to a hospital. While he was in hospital, he required a right below knee amputation, and upon discharge from hospital, he developed a new wound on the other heel, on his left heel. This is very, very common. On discharge from hospital, the notes in the hospital stated that there was simply a blister on his heel, but home care made it clear to us that it was actually much more, looked a lot like this, in fact, his other heel. So I would first like to ask, what are the causes of this wound? And I want to see if I can see, if you could put, I would love to see, people can comment what they feel are the causes of this wound. If you want to enter them in the chat, that would be great. Any ideas for what you feel causes of this wound might be? So some of the causes, the most common, the most obvious cause is pressure. And I will say that, yeah, I see Kim. Yeah, people are saying pressure, people are saying ischemia, poor nutrition, pressure. So yeah, these are all correct. So pressure in a wound that is at high risk because of other causes that I'll talk about, you have a little bit of pressure and a little bit of friction, a little bit of poor nutrition, the wound is much more likely to occur. So yes, this is a pressure injury, but there's multiple causes for a pressure injury. Pressure is only one of them. Friction and shear are two other causes. And the difference between, I don't know if anyone knows the difference between friction and shear. The way I kind of think about it is if you have a picture like an older patient who's in a hospital bed, the head of the bed is tilted up, say 90 degrees, and she's kind of all slouched down in the bed. Friction is the force between her skin and the blankets rubbing in the same direction as she slides down the bed. Shear is the force between her skin and her subcutaneous tissues moving in the opposite direction as she moves down in the bed. So friction often occurs during movement in the bed. Shearing often occurs when the head of the bed is too high and the patient slides down, or during transfers that are not done appropriately. So often when you see those really tiny, narrow wounds that are very deep on the buttocks, those are often due to shearing forces. So pressure, friction, shear, moisture. So stool incontinence is really more of a problem than urinary incontinence, generally speaking, and nutrition. And when it comes to nutrition, the most important is just total calorie, total protein. None of those, you know, I get asked questions, vitamin A, C, E, zinc, arginine, none of those have actually been shown to improve wound healing or prevent pressure injuries. So I just usually recommend that if there's any kind of a question, to make sure there's a dietitian involved. So if you can consult a dietitian, then that would be ideal. So in terms of risk assessment tools, there are multiple risk assessment tools. The most common one is probably the Braden scale. Many of you may have used one, and these need to be done in a certain schedule in acute care. They need to be done every 24, 48 hours. Long-term care every week for the first month, and then quarterly. And then home care, I believe there's different recommendations for, you can find out from your own agency perhaps what the recommendations are, but they need to be done on a regular basis. And generally Braden scales, the studies that have been done show that they're most useful if they are done by somebody who has had training in how to do Braden scale. Often these may be nurses. Okay, so another common question that I get asked is what type of bed to order, what type of mattress is best. Mattress is not the solution, as many of you probably already know, but it can help in terms of managing pressure injuries. But the way that I think about it, because there's many, many different brands, is that there's simply really two categories, non-powered and powered. And so powered mattresses are just the ones that, you know, require electricity and are plugged in, and the non-powered are your standard hospital mattresses. The non-powered mattresses are not the same as just a bed at home. In a facility, generally all the mattresses in a facility are these non-powered mattresses, which do offer some pressure reduction. And the powered mattresses are the ones that you often will see in an ICU. The difference is that powered mattresses can cost upward of $20,000 to $30,000, and so you don't want to use those unless you really have to. The recommendations generally are that non-powered mattresses should be used throughout a facility. In home care, you know, when most of people are going to be in their own beds, if they're at high risk of developing a pressure injury, perhaps a non-powered mattress may be ordered. That might be a good idea. But powered mattresses are really only required for management of existing stage 3 or 4 pressure ulcers, and never for the prevention of pressure injuries. And then often these wounds occur while somebody's on the operating table. And so overlays should be used for those, if that concerns any of you or is related to what any of you are doing. In terms of wheelchair cushions, again, there are multiple types of wheelchair cushions, and they vary quite a lot in terms of cost and efficacy. Probably the best ones and the most expensive are, you can see they're the black one to the top right of the pictures of Roho. And there's also something called a matrix cushion. The thing with the Roho, they're about $300. The thing with the Roho is that it needs to be inflated properly, so it's not over or under inflated, because that can cause more skin issues. So the patient and or physical or occupational therapist needs to be checking that cushion regularly to make sure of that. They are covered by Medicare generally. The kind of turquoise-ish green cushion that you see there is an example of a gel cushion that's about $90. So those are great for prevention. I shouldn't have to say this, but I just want to make sure that everyone out there knows that there's never a role for a donut-shaped cushion, because that just increases pressure and risk of pressure injuries. So for anybody living at home who is wheelchair dependent, should be seen in a wheelchair clinic every couple of years to have their cushion and wheelchair checked. Should have an occupational therapy home seating assessment. So the OT should check like where they sit in the kitchen, their living room, because, you know, obviously if they sit on a couch in their family room, just because the couch is soft doesn't mean it's reducing pressure in the right places. And they should also have a regular occupational therapy home safety assessment. And the reason the home safety assessment is important is because what the OT will do is check how the patient is transferring, for example, from commode to their wheelchair, or from their bed to a chair. And if there's a lot of friction and shear going on, they may suggest like a Saska pole or 2-person assist or something else that can reduce pressure. So I will say, getting back to the whole idea that what you put on the wound is not the most important thing, that there are more than 1,000 wound care products available. And unlike medications, wound care products don't need to show proof of efficacy. They're actually under the umbrella of medical devices, and so you don't need FDA approval. So marketing can be direct marketing to really anybody. So you just need to kind of know what you're looking for and how to evaluate a product. There are we did a study that showed that there were financial conflicts of interest published in over 65% of wound care studies, and in the rest, the conflict of interest wasn't even mentioned. So there's a high degree of conflict. So just know that when you're reading or seeing these ads. There's also little evidence to suggest one specific dressing over another, and there's also little evidence to show that a VAC dressing, negative pressure therapy, or hyperbaric oxygen improves healing in pressure injuries. I will say there is some evidence to show hyperbaric oxygen works for diabetic foot ulcers, some. And also in the very large pressure injuries, we will use a VAC sometimes to just reduce the size a bit. And I'll also say, remember we're talking about chronic wounds here. Post-operatively, those acute wounds, that is not what I'm talking about. And VACs are often used for those post-op acute wounds, and that's a different situation. One of the things that helps in terms of what to decide, because there are so many dressings available, is to at least know what not to use. And people that do develop wounds have used multiple dressings in the past. And so usually often get hypersensitivity reactions to these common allergens. So things like neomycin, bacitracin, triple therapy, ointment, those kind of things I never ever use. They can be used short term, again for like post-surgical patients, maybe for a couple of days, but for chronic wounds and long term, I would not use them. The old Duoderm adhesives, oh, they're not that old. I guess people still use them. I rarely use those. They have something called colophony, which is a hypersensitivity agent. What else do I have down here? Lanolin. Often you'll see aloe, lanolin, a lot of these creams, and those can cause hypersensitivity. And of course, you all know fragrances, those kind of things can cause reactions as well. So these are all things to be extra careful about when thinking about what to use topically. So then again, because there's so many name brands out there, it's a really good idea to kind of know about what you want from the dressing. So then you can see what your agency or institution has in stock or is on their formulary. Or if a physician or provider orders a certain wound care dressing, then you can say, oh, we have this and that's a good substitute. So I like to think about it as function. So what you want from a dressing in a healable wound, and we'll talk about what's healable and non-healable shortly, but what you want from a dressing is something that provides moisture balance, not too wet, not too dry, bacterial balance, and some debridement. And so, sorry, my dog in the background. There are dressings that provide all three of these. Some examples are cadexmariodine. The brand name is Iodosorb. I'm so sorry about the barking. Silver, there's many different silver dressings. Aquacel, Acticoat are some brand names. Hydrofera Blue, it's honey dressings. If you have a dressing that is draining if you have a wound that's draining quite a lot, you can use foams or alginates. Alginates are made out of seaweed. They're very absorbent. And if you have a very superficial wound that's not draining much, you don't need any debridement or anything, you can use Silvadene, or if it's a non-healable wound, an antiseptic. Debridement, so Santal is a very common type of topical dressing. You know, the surgeons like it a lot, and there's nothing wrong with it. That's the collagenase here. Santal is the brand name. The reason I don't use it a ton is because it only provides the debridement without bacterial balance. So Silver Gel really does the job of Santal, plus has an antimicrobial agent in it. So it's fine to use Santal, just realize there's no antimicrobial component to it. And actually, when you think about it this way, I don't know if anyone would like to respond, why, what their thoughts are on wet to dry dressings. I want to go back. I'm trying to look at, chat. If anyone wants to type in their thoughts on wet to dry dressings, looking at what you want from a wound dressing, can you tell me why you think, what you think a wet to dry dressing does. Do you think it provides moisture balance, bacterial balance, debridement, all of the above, none of the above? I'd love to hear your thoughts. I'm sure you're probably given the orders to use wet to dry dressings quite a lot. Maybe I'm wrong. Anybody? Well, I'll go ahead. So the reason why wet to dry dressing oh, there you go, provides debridement as it dries. That's exactly right. Chemsil hose. I don't know what the brand, what that's an abbreviation for, but that's exactly right. What happens is the reason it doesn't provide the moisture balance as most people think is because when you put it on, when you put a wet piece of gauze on the wound, it is very wet. But in order for it to work as it's intended to work, you need to wait until it dries out, so desiccates the wound, and then remove it. And so the wet to dry debrides. So in other words, you put on a wet dressing, it dries, you remove it, so it debrides. So it becomes either too wet and the wound can become very macerated, or too dry. So it doesn't provide moisture balance, it doesn't provide bacterial balance, but does provide debridement. It's also nursing time intensive, as you know. It needs to be done 4 times a day for it to work effectively. It can be painful. And there's multiple other dressings now that can do the job. So for chronic wounds, again, be reminded that I'm not talking about acute post-surgical wounds here. So for chronic wounds, there's really never a role for wet to dry dressing. Okay, so how do you know when a chronic wound is infected? And I think the short story here is that new or worsening pain in a chronic wound is the most sensitive sign of infection. So even in a diabetic foot ulcer, which is often not painful by definition because the patient has neuropathy, if they have new or worsening pain in that wound, that's a really good sign of infection. And often it can be treated without doing any kind of a swab. If a swab is ordered, the way that the swab for culture, the way that it's done is really important. So you need to push the swab into the wound. You need to clean the wound first, I will say. You push the wound, the swab into the cleanest part of the wound, because if you don't, you're just going to get white cells, dead tissue. So put the swab into the cleanest part of the wound with some pressure, turn it 360 degrees, and that's it. You don't need to do the zigzag or anything else. So push it, turn it 360, and that's it. That's called Levine's technique, and that's the best way to swab a chronic wound. So I said pain was the best indicator of infection, because a culture doesn't always is not always indicative of infection, but other signs of a chronic wound infection are friable granulation tissue, so the wound bleeds very easily when you touch it. Hypergranulation tissue. I said foul odor. I mean, all wounds smell quite a lot, but if you've certainly noticed a change or an increase, you might consider that there's infection. And very importantly as well, if you feel that you're addressing all the causes for this wound not healing, and yet it's still continuing to not heal, or if it's getting worse, then it might be infected. That might be a sign that a swab should be done, or antibiotics should be started empirically. And certainly if a wound probes to bone, it's osteomyelitis unless proven otherwise. So the providers may decide, if you're going to tell the provider that you think you feel bone, then they may want to see the patient or order an X-ray or MRI to see if there's more definitive osteomyelitis. So just want to quickly go through some practical sort of tips about local wound care and stages of pressure injuries. And keep in mind that staging is just for pressure injuries. I mean, there's lots of other kinds of chronic wounds, like I mentioned before, diabetic foot ulcers, venous stasis injuries, dehiscence post-op, arterial wounds, vasculitis, pyoderma gangrenosum. There's a whole lot of different kinds of chronic wounds, but we're just talking about pressure injuries here. And staging, you just stage pressure injuries. There are ways you can grade diabetic foot ulcers, but it's not a common thing that you would see. So stage 1 pressure injury is when the skin is not broken and it's just non-blanchable redness over bony prominence. So if you see redness on buttocks, for example, there's a lot of different causes for buttocks erythema. Like you could have moisture associated skin damage, which is not pressure. You could have a dermatitis. So you want to make sure you're looking on a bony prominence, or if it's not a bony prominence, is there something else that's causing the pressure, such as medical device? We've seen like everything from a urinary catheter causing pressure injuries to walkers when people on elbows. We see pressure injuries on ears, as I'm sure many of you have. So if you do think it's a pressure injury, it should be on an area of pressure. So stage 1, you're really trying to prevent it from getting any worse. So, you offload the patient best you can. In terms of repositioning, nobody really knows exactly how much to reposition, but the general guidance is every 2 to 4 hours on a regular mattress, maybe every 4 hours on a powered mattress, but somewhere between every 2 to 4. So for local wound care, to apply a barrier cream like zinc oxide, Sensicare, Vaseline, so a non-allergenic barrier cream, probably twice a day if the person is incontinent, it's on the sacral area. So stage 2s are very, very superficial. I will say that one of the most common mistakes we see in terms of documentations from the providers, as well as nursing staff, is if the wound is very tiny, they'll call it a stage 2 automatically, but that's not true, because remember, staging has to do with the depth of the wound and not the size. So even if it's a tiny wound, if you see any yellow in there, if you see any real depth, it's a stage 3. So a stage 2 looks like a skin knee, really like an abrasion. So you could use just an antimicrobial, being careful, like I said before, not to use the common allergens like bacitracin, etc. So you could use Silvadene, for example. And we like to use a cover dressing that doesn't cause skin tears, like a Mepilex is a brand name for a silicone adhesive. So stage 3 has a little further depth, goes into the subcutaneous tissues. And here that wound may require some packing. So if there's any depth, the wound needs to be packed. And we say fluff, don't stuff. So you don't want to put too much in there, but you want to fill the whole cavity. So if it's a healable wound, meaning a healable wound is one where you think you can reduce or eliminate the underlying causes, and the patient has a good chance of recovery and is not at end of life. So you can pack with a moist wound dressing like silver dressing. And if it's not healable, because there's not enough blood flow, or the patient is at the end of life, or is not adherent with offloading, you can pack with an antiseptic like betadine. And if it's healable, the wound will need to be debrided. So some of the nurses out there may be able to do some surgical debridement if you have some training and you're comfortable, or you may need to ask the provider to do it, or to send the patient out to someone who can do it. And if the wound is down to muscle or bone, then it's stage 4, and this wound definitely needs to be packed. Again, if it's healable, use a moist dressing such as silver, and if it's non-healable, an antiseptic, packing like betadine soap gauze. If it's a very large wound, negative pressure therapy or back may be used for some time, and probably needs surgical debridement to get rid of all that dead tissue. And the provider may consider a referral to a plastic surgeon if the patient is a good candidate for a flap. And I will say that there's not a lot of great candidates for a flap. It needs to be relatively a younger person who's like in their 40s or 50s. Maybe a spinal cord patient, as opposed to a geriatric patient, where you can't reverse the underlying factors. And I say a younger patient with spinal cord injuries because often it's when they've been acutely ill, that they've been more immobile than usual, that they might develop a wound. And they may be a good candidate because they can offload afterwards. And an unstageable wound is simply a wound where you can't see the base, so you don't know how deep it is. So any eschar is automatically an unstageable wound, or if there's a lot of yellow necrotic tissue, it's going to be unstageable. And it needs to, if it's healable, there's good blood flow, then it needs to be debrided so you can see the base, so you can send the patient to whoever, the provider, or if you're comfortable doing the debridement, if you've had training, you might do that. And you also the provider may also send the patient for an X-ray or MRI to see if there's any bone infection. So this is a really, really important stage, deep tissue injury stage, which wasn't counted as a stage until about 2008. And it's important, I think, very important in home care to look to diagnose. And the reason is the other stages usually progress from stage 1 to 2 to 3 to 4. But a deep tissue injury can look like this one day and then can look like a stage 4 the next day. The skin is not broken, generally speaking. It looks like a bruise, but it's often boggy. If the patient has some feeling, it might be tender, often warm, again, on a bony prominence or a place of pressure. And if offloaded properly, it may just simply resolve. But if the pressure continues, it can really deteriorate. So it's really important to document and apply a barrier cream and offload just like you would for stage 1, sorry. I kind of mentioned this before, that very few pressure injuries are going to be good. Patients with pressure injuries are going to be great surgical candidates, and it's usually younger patients. So in terms of how to write a wound order, I know you all may be on the receiving end of these sometimes, but if you can maybe if you're in the position where you can give some advice for how to write the wound order, I find this helpful. The order should say to cleanse with, wound cleanser, non-toxic wound cleanser, saline or still water. And then in terms of dressing, apply blank, or if it's deep, to pack with blank. Then to cover the dressing with, and usually soft silicone would be my preference, like a Metholex. If it's a leg wound and venous stasis with edema, which we did not talk about today, but I just wanted to put it in here so you would see where it goes, then the compression would go right there. And then most chronic wounds, the dressings can be changed 3 times a week. There's a lot of drainage, and you can simply add a foam or alginate to the top. And sometimes you may need to increase the frequency. So for pressure injuries that just don't seem to be healing, you want to make sure that you've eliminated all the underlying causes, ensure any infection excuse me, has been treated. If it's a leg wound with edema, you may need compression. And if drainage is the problem, maybe you can add some foam or alginate. And if it's none of the above, then the team needs to have a discussion about whether this wound is actually healable. And this actually brings us back to the whole idea of COVID-19 and pressure injuries, because I hope from what I've talked about, I hope to have kind of stressed how important the underlying factors are and healability is for pressure injuries, and not just the dressings. So in the setting of COVID, when you have very ill patients with COVID or otherwise, they're going to be at increased risk for pressure injuries. Yes, because they're less mobile, but also because they have less overall ability to heal. So you kind of need to be more on guard, checking their skin. Skin checks need to be done daily anyway in the hospital and home care whenever there's a home care visit where any dressings are changed. I think it's tricky to be doing preventative home skin checks at home. So I think you just have to see whatever your agency's policies are with regards to that. But certainly somebody who has COVID or is acutely ill in any other way is going to be at increased risk, and not just because of their limited mobility, but because of their overall reserve. The other thing too that we notice is in the setting of COVID, when staff is stretched to your capabilities, then we all just don't have time to be doing all the things that we normally do, and skin checks is one of them. And so that's yet another reason why a lot of these pressure injuries develop and worsen. So you have sicker patients, a more stressed, more stretched staff. And so it's just something to really remember to look at the skin, because I'm sure you've all heard it, it's much, much easier to prevent a pressure injury than it is to treat it and heal it once it occurs. If you want to look at any guidelines, specifically the NPUAP, the name has changed now to reflect that it's pressure injuries, not pressure ulcers. you can look at their guidelines. I've got some links there for you. And if there's any questions, I am more than happy to answer them. So please go ahead and type them into the chat or the Q&A, and I'm happy to discuss anything.
Thank you, Dr. Reddy. That was incredible and sobering. And so just to reiterate what Dr. Reddy said, if you can put your questions in the Q&A, we will enable Dr. Reddy to answer them. So we will just be comfortable with silence and see if there are any questions.
I was going to say, I wanted to mention Linda earlier had said pressure and ischemia were the causes of that heel wound. And I meant to say that that's, yes, the ischemia part of it, that's a really good thing to think about. Whenever you have lower limb foot wounds, you always need to feel for a pulse. If there's a pulse, there's more than likely enough arterial flow to heal. But if there's not a pulse, you might want to tell the provider, because they should then go ahead and order non-invasive vascular studies or Doppler studies. I'm not usually a fan of the handheld Doppler because I don't think it really tells you what you need to know for wound healing. It's good for other things, like just to know if there's any arterial flow, but it doesn't tell you if there's enough flow for wound healing. So yes, so for a wound on the lower limb or foot, you always have to check to make sure there's enough arterial flow to heal. So that was a good point.
So I have a question.
Mm-hmm.
What advice would you give nurse managers who are managing teams of nursing assistants, home health aides, personal care aides, and other caregivers who are the ones that are sort of there day to day with older adults in their homes? And sometimes they minimize or kind of don't always recognize the early stages of a pressure ulcer or pressure injury. What kind of advice or inspiration or suggestions do you have for nurse managers who are managing these teams of caregivers who are the front line of identifying early stage pressure injuries?
Yes, that's a great question. So I think one of the things that you should have as an agency is your own policy. You need to develop pressure ulcer prevention and treatment policies, and you can, speak to experts about how to develop it. And then you have written guidance that at least you're not reinventing the wheel every time you have this conversation with the direct care workers. You can go from there. And then in terms of prevention, what can be on your policy is the frequency that you want those skin checks done. Like I mentioned, I think that it's tricky to know how often is practical to do it in the home care situation, but you can decide as an agency when you're going to have those done, and then you can directly tell these workers to do it. And also in that policy should be where to be checking for the highest risk pressure injuries, and that would include bony prominences, as I mentioned, and any medical devices. And then what to do when you see any discoloration, who to tell, how to document it, and how to document any progression as well. Okay, so do you want me to read it? Do you want you to read it, Charlene?
No, go ahead. It's a small group, so you can go ahead.
Okay, this is a great question from Linda. There have been several cases reported of hypercoagulopathies and distal vasculature for patients with COVID-19, and sometimes 2 weeks after the onset. And these are sometimes coded inappropriately as pressure injuries. Do you have guidance for us in determining these versus pressure injuries? Okay, such a great question. Okay, first of all, let me say that for most providers, I think that our differential diagnosis of wounds is very limited. So everything gets written down as either a decubitus ulcer or pressure injury. So this isn't your question exactly, but I just wanted to stand on my soapbox here and say that decubitus ulcer is meaningless. It doesn't mean anything. It doesn't tell you exactly what it is. So that's a phrase I wouldn't use. and it is a good point that you say that you see things that are overcoded as pressure injuries, because I think that that's exactly right, that people look at wounds and often will just write down pressure injuries. So if it's not on a bony prominence, or if you don't have another reason for that wound being there, like a medical device, no other pressure, then it's not a pressure injury. If you see like the distal vasculature, like you said, you'll often see these wounds on distal digits, for example, toes or fingers, similar to arterial wounds that you'll see on toes, or when you see like emboli in certain conditions on toes. And those should be, you can write those, you could document those as chronic wound secondary to COVID-19. You could say secondary to an infectious disease, but it's not a pressure injury. So I think that that should make it, and you can write down, I think it's, as I mentioned before about documentation, nobody's going to fault anybody if you write down your thinking, even if you're incorrect. For example, if you say, we don't believe this to be a pressure injury because it's not on a bony prominence and there's no other source of pressure. We think it's due to hypocoagulopathy or whatever else, and that is perfectly reasonable. I think the most important thing is to show that you considered it, just like what I had said earlier about if a pressure injury is not healable, to at least write down what your thinking is, and nobody can fault you for that. So I think that's very reasonable. I hope that answered your question.
That was fantastic. Yeah, and Linda says thank you. So let's see if there are any more questions. And if not, we will wrap up.
Well, I left my email there. I'm always happy to answer any questions if anybody wants to email me.
Okay, Dr. Reddy, thank you so much. I'm going to share my screen again and just, well, I think I'm going to share my screen again and just take a few moments to celebrate Dr. Reddy's expertise. I learned a ton. I really appreciate you sharing this, sharing your insights with us. And so now we're going to just take a moment and thank the same folks we thanked at the beginning, the Emergency Preparedness Network. If you have not joined, just reach out to that email address. Minka, again, info@minka.org if you're interested in joining, if your agency isn't a part of the network. And of course, if you are interested in working with Learn Care Together, just reach out to me at hello@learncaretogether.com. Thank you so much. And we'll see you, hopefully we'll see some of you on Thursday and throughout the rest of the month for the upcoming webinars. All right.
Yeah, I was just going to say, so Tiara had asked, will the PowerPoint be available for review? And that's fine with me.
Oh, absolutely. Yes. The recording and slides will be, I think Nelson answered it. The recording
Yes, I did.
will be sent out to everybody, and you can share them. You can share the links with your colleagues, because the more people that can hear this and learn from this, the better. Again, thank you everyone for joining. Dr. Reddy, did you have something else?
Yeah, I was going to say, I want to thank all these people that you thanked, the Maryland Department of Health and the Home Care Association and the Emergency Preparedness Network, and you, Charlene. And I also wanted to thank all you guys on the call for everything that you're doing every day, because that's really where all the hard work is. So I appreciate it.
Oh, they thank you too, as we can see in the chat. All right, everybody, have a wonderful rest of your week. We're going to hang up. Bye-bye. Thank you.
Bye.